We're now going to explore the drugs that are used to treat pain and inflammation. These drugs are, of course, very important in our practices. We see so many patients, so many clients that, for various reasons, have pain or inflammation or both. So clearly, these are some of the more critical and more common drugs that we see. And of course, they're very synergistic with what we're often trying to do. At the same time the drugs are trying to treat these problems, our interventions, physical agents, manual therapies, exercise techniques are also trying to decrease pain and inflammation. So clearly an area where physical therapy and drug therapy are closely linked. So we're talking about two different problems: pain, which is treated by the analgesic meds, and inflammation, which is treated by the anti-inflammatory meds. We'll start by talking about analgesics, and in this section of the course we'll cover the real heavy hitters of the analgesic meds, the opioids. In part 2 we'll cover the non-opioids. Likewise, analgesic anti-inflammatory medications, we have two major options there that we'll cover in part 2 of these drugs. And we'll cover the NSAIDs and the anti-inflammatory steroids in the next section of the course. But for now, we'll get started with the opioids. So opioids, often referred to as narcotics, we're trying to get away from the word narcotic because it refers to sleep. Narcosis, of course, is sleep, refers to sleep. A better term is the chemistry of the drug, which is an umbrella term called an opioid medication. You'll still hear the word narcotic used frequently, but like I said, we're trying to get away from the narcotic term and apply this more chemical term, opioid, to cover all the drugs in this group. We'll start with those. As I said, we'll then segue over in the next section of the course to the non-opioids, and we'll see that these are often very important medications. Not as strong typically as the opioids, but very common, very important for our patients, and that's where we'll see the NSAIDs and another drug called acetaminophen. So first, the opioids. They are not anesthetics. Typically, they don't remove the pain from our patient. They don't obliterate the pain. What they often will do is alter the patient's perception of the pain. I always say it's like putting the pain on the back burner. When they work well, the patient may still be aware of the pain, but it's simply not consuming the patient's attention, which is incredibly helpful for what we're trying to do. It's very hard to engage a patient in physical therapy if the patient's in pain. So by doing this, the patient is much more perceptive and much more engaged in our interventions. They are useful in all kinds of pain, but we tend to reserve them for the more moderate to severe pain, and often constant pain. They will work in sharp, intermittent pain, but they're usually much better in moderate to severe, fairly constant pain. So they're indicated in both acute situations. We see them very often after surgery, after trauma, but also in chronic situations. Opioids have always been a mainstay in treating cancer-related pain, improving quality of life, especially in advanced cancers. But we do see them used in other chronic situations, including chronic back and neck pain. And I'll try a little later to explain why we're trying to rethink how we might use these drugs more effectively for long-term periods of time, for more chronic situations. So first, a little history about opioids. They're not new drugs. They've been around for at least 3,000 years. Some people feel even longer. Clearly they came from a natural source originally, and that was the opium poppy. And we often hear reports in the literature about opioids being used for many, many different conditions, for their sleep-inducing properties, for various medicinal purposes. Back into the early part of the 20th century, or up until the early part of the 20th century, opioid drugs were often found in lots of medications. We, of course, realize now the potential for serious side effects, and these are, these are important drugs. So there was a real effort to cut back on the availability of these drugs and control them much better. But again, they're not new. They've been around for thousands of years. And there are a lot of opioids. You can recognize some of the generic and as well as trade names. Here's just a partial list of the common opioids that we see used clinically. Codeine, again, very common use for pain and cough medications. Morphine is probably the considered the grandfather of this group, or the prototype opioid, at least in this country, and a lot of other opioids are compared to morphine in terms of their effects, beneficial effects, as well as side effects. But again, you can see there are some pretty well-known drugs in this group. Now, not all opioids are alike. We often talk about a strong agonist, and pharmacologically an agonist is a drug that binds to a tissue and causes some effect, exerts a direct effect on that tissue. So some of the opioids are considered more strong than others. So of course we see morphine, meperidine, fentanyl, very powerful opioid, short-acting but very powerful opioid. Then there's a slight step down to the more moderate opioids, or the moderate agonistic opioids, like codeine, oxycodone, still very strong pain meds. We actually have a third group here that bind to tissues but do not activate them. In pharmacology, that's called an antagonist, or simply a blocker, a drug that binds to a tissue and doesn't do anything, just sits there. But what it does do is prevent other chemicals from activating that tissue. So these opioid antagonists are very important in overdose. If a patient is brought into the emergency room with an intentional or an accidental opioid overdose, they can administer a large dose of the antagonist, which will reverse the effects of the overdose. And finally, we have this last category of mixed agonist-antagonist, which might sound a little confusing. Well, what does it do? Does it stimulate the tissue or does it block the tissue? These drugs actually do a little bit of both at the same time. What we find is there's three major families of opiate receptors in the human body, at least three. And what these drugs do is they stimulate some tissues and decrease pain, which is of course the beneficial effect. At the same time, they block other opioid tissues and may prevent some of the side effects, including decreased respiration and maybe even decrease the chance of addiction. So these are not as well known. They're certainly not as maybe as good at decreasing pain as the more powerful opioids like morphine and fentanyl, but they may be useful in some patients who have other problems or other risk factors for respiratory depression or even addiction. So the point is, we've got this array of different options to use for different types of patients with different types of pain. Now, the fact that the opioids have been around for thousands of years has not really decreased our interest in how they work. And we'll start first with the primary way that opioids work, and this has been known for many years. And what opioids do is they act at several sites within the central nervous system, both at the spinal cord level and upwards through the brain. And what you're seeing here is, of course, key places in the CNS where pain is transmitted from one neuron to the next. And what these drugs do, their primary effect is to bind to presynaptic terminals at key junctions in pain pathways and decrease the release of transmitter from the presynaptic terminal, at the same time binding to postsynaptic neurons in pain pathways and decreasing the excitability of the postsynaptic neuron. And I think this is why they're so powerful. They don't just work at one place in the central nervous system, they work at many locations, and they don't work at either the pre or the postsynaptic neuron, they work at both. This slide is showing, again, a schematic representation of how they affect synaptic transmission in pain pathways. So the presynaptic terminal in this case contains some pain transmitter, like substance P. And as you can see, there are receptors for the drug located both on the presynaptic terminal on the left and on the postsynaptic neuron on the right. So the red triangles represent the opioid drug. And when an opioid drug binds to the presynaptic receptors, it decreases the release of the neurotransmitter. And we know now that this involves a decreased entry of calcium into the presynaptic terminal. If less calcium enters, less vesicles bind, so less transmitter is released. At the same time, some of the drug binds to the receptors on the postsynaptic neuron, and either open potassium channels or open chloride channels in either case decrease the ability of the postsynaptic neuron to reach threshold. So this decrease in excitability again makes it less likely that the postsynaptic neuron is going to reach an action potential and continue the pain impulse upwards towards the cortex. So it's this combination again of presynaptic and postsynaptic effects that probably explains most of how our opioid drugs blunt the activity of incoming pain information. Now, the effect of opioids on these synaptic pathways has been known for quite some time. More recently, it was discovered that opioids can also affect other activities in the pain transmission. For instance, there are opiate receptors at peripheral sensory neurons, typically in joints. And opioids can be even produced in those joints, bind to these receptors, and decrease the sensitivity of the neurons that initiate the pain. But again, this is probably true for inflammatory joint pain. It may not be true for other types of peripheral pain. But still, it's generated an interest in how we might capitalize on this effect and maybe develop opioids that selectively affect this type of pain in specific patients. More recently, it's also been discovered that opioids may affect outgoing information, descending or efferent pain pathways. We know there are endogenous outgoing pathways that help us control pain. Normally they're inhibited because pain is usually a warning that something's wrong, and that message should get through to your cortex. But if an opioid can remove some of that inhibition, these outgoing pain pathways may be more active. So the bottom line is opioids are clearly a very complex drug that affects several aspects of pain. So in summary, we know opioids can control pain in at least 3 ways. First, opioids can decrease the synaptic activity, the diagram you saw a minute ago, to decrease the release of transmitter and the reception of that transmitter in many ascending pathways. At the same time, may decrease the sensitivity of sensory neurons in specific types of pain like inflammatory joint pain. And finally, may activate or disinhibit descending or outgoing efferent pain pathways. This, I think, explains why these drugs are so effective at what they do. Now the bad news. We know that opioids are very serious drugs, and they do come with some potentially serious adverse effects. I've categorized them into first relatively minor. That doesn't mean they're not important, but they're maybe not as life-threatening as other side effects of the drug or adverse effects. These drugs invariably cause some sedation. How much depends on the dose, the type of patient, and how the drug is administered. But it's pretty understanding why these drugs do cause some sedation. Secondly, they can cause mood changes. In some patients, it's often a euphoric type feeling. However, in other patients, maybe older patients especially, they can cause the opposite reaction, almost a dysphoric or a combative type mood. So the mood changes vary depending on the patient, patient's age, and so forth. They can cause confusion. Likewise, typically in a patient that may already have some cognitive dysfunction or may be already a little bit confused. They can cause nausea and vomiting, especially after they are first administered. Again, related mainly to the route of administration. If a person takes them orally or gets a parenteral administration, like a shot into the butt, there's probably going to be some nausea and vomiting. Fortunately, it's usually transient and only lasts for a day or two. Constipation is actually a pretty serious problem because it's not transient. It will last as long as the drug is administered. So if a patient is going to be on an opioid drug for any length of time, more than a few days, oftentimes they'll administer a laxative and maybe even a stool softener along with the opioid. And it's a good use, a good synergistic use. We don't want to overuse laxatives, but this is a situation where constipation is almost invariable. So the use of a laxative at the same time will really prevent some problems. And this becomes very important in some of our patients who are prone to fecal impaction, like patients with spinal cord injuries. More serious side effects involve the fall in blood pressure when a person stands up suddenly, orthostatic hypotension. And this is not unique to the opioids, but it is very common, and it's important because the drug is going to cause the orthostatic hypotension, but we as clinicians are probably the people that are going to invoke it by getting the patient on his or her feet. So it's something you have to be much more aware of. Oftentimes if a person is coming out of a fairly long surgery, like a hip replacement or a knee replacement, they're also still recovering from the effects of the anesthesia, but if an opioid is used, it's pretty invariable. So we have to be more aware of that and more conscious of being careful. Very slowly, progressively getting the patient more upright. Respiratory depression is usually the most serious side effect in terms of high doses or even overdose. It's usually the cause of death in opioid overdose. Opioids decrease the sensitivity of the respiratory control centers in the brainstem. And basically you need a higher increase in CO2 or a larger drop in oxygen levels before the respiratory centers respond. And if, again, there's high enough dose of the drug or an overdose, the respiratory centers in the brainstem stop functioning. So we're watching our patients carefully, checking their coloring, make sure they're not getting cyanotic, make sure that they're not difficult or have difficult or labored breathing, and also that maybe even check their pulse oximetry, their saturation, their oxygen saturation. And finally, the potential for abuse and addiction is always a big concern. Patients are aware of this, their families, the caregivers, everyone's aware that this is possible. But it's a very complex situation, so we want to spend a few minutes now talking about the potential for abuse and addiction related specifically to opioid drugs. We hear the word addiction very often, very commonly used term. It's not a good term because it's very imprecise. It doesn't specifically define what's happening in the patient. Better terms to describe this are tolerance and dependence. Tolerance is you have to provide more drug to achieve the same therapeutic effect. A patient may start on a certain dose and the dose works. It achieves good analgesic effects, but after a period of time, maybe 3 weeks, 4 weeks of continuous use, you have to turn up the dose. You have to increase it to get the same effect. Physical dependence is easier to describe. It's the onset of withdrawal symptoms if a drug is suddenly discontinued. And this doesn't occur with all drugs, but if a drug has an addictive potential, physical dependence is the onset of this withdrawal. So again, a patient that maybe has been on an opioid for a month or more at high doses, if they suddenly stop, will exhibit very obvious symptoms of. Why does opioid tolerance occur? It's been studied extensively and it's still not exactly clear. We think it might involve some change in the way the receptor interprets the drug and, more important, sends a signal from the receptor to the cell. Like I said, it's complicated and the details are still being investigated, but we think with long-term use there's simply a change in the way cells in the body respond to this drug, and that may be true for lots of different types of tolerance. The time course, however, pretty predictable with opioids. It actually begins after the first dose, but it's not noticeable. And if a drug is going to be used for only a few days, it probably will not be noticed. But it becomes obvious after about 2 to 3 weeks at high dose. Short term, less than that, again, probably not going to be a problem. And it lasts about 1 to 2 weeks after the drug is discontinued. What that means is the symptoms of withdrawal that we'll see in a minute have disappeared within a week or two. With addictive substances or with people with addictive potentials, that doesn't mean that they might not still want the drug. That's a little different. That's psychological dependence, and that may last indefinitely. But the actual physical. So we should talk a little bit about physical dependence. What does it look like? When does it occur? In terms of opioid withdrawal, these symptoms can begin within a few hours, 6 to 10 hours after the last dose. Which is why people who are addicted to opioids often are looking for their next dose of the drug or their next source of the drug within a few hours after taking a dose. These withdrawal symptoms peak within about 2 to 3 days after the last dose. And they typically last again about 5 days, so well within a week. And again, these are physical symptoms. Individuals who are addicted or possibly have addictive potential may still crave the drug for forever. Again, different problems. Psychological dependence, which is even more. So what are some of the withdrawal symptoms? Fairly well documented. Things like body aches, weakness, fatigue, lack of energy, goose flesh. The erector pili muscles on the skin become activated, and the skin, because of the sweating response, looks like cold turkey. And the term going cold turkey came from this appearance of goose flesh. People have leg cramps and tremors, and the idea of kicking the habit came from these leg tremors. People would look like they're kicking. But other things like fevers, sneezing, runny nose, some GI problems, nausea, cramping, vomiting, loss of appetite, obviously the irritability, I mentioned sweating, the yawning, and fast heart rate, tachycardia. Not fun, not pleasant symptoms, and as I said a minute ago, often peaking within a few hours after the last dose. So what is the risk of opioid tolerance and dependence, or simply what is the risk of addiction? It's actually very minimal if the patient does not have a personal history of substance abuse, not just to opioids, but to other addictive substances like alcohol. If the person does not, the risk of substance abuse for opioids is minimal, and the pain is real. It's physiological, not psychological. Patient recovering from surgery, patient recovering from trauma. And most important, that the dose the patient receives is fairly well matched to their level of pain. It looks like if a person has a certain amount of pain and you give the right amount of the drug to treat that pain, it's almost like the pain soaks up the drug, or the drug has a job. Its job is to treat that amount of pain. If you give well beyond that patient's pain level, it's almost like the leftover drug contributes to the addictive potential. So the question has always been, how do we best manage this? How do we best match which led to the development of PCA, or patient-controlled analgesia. As the name implies, the patient is much more in control by activating a small pump, which allows them to self-administer a relatively small amount of the drug, of the opioid. And these pumps vary in terms of their sophistication, the type of pump. Clearly the pump has to be programmed in some way to prevent overdose. And you can see on this example, this is a simple syringe driver pump where the electronics of the pump are programmed to provide a certain amount each time the patient activates the pump, and then lock the pump out for a certain amount of time before the patient can administer the next dose. And those are the two key variables. They're called the demand dose, that's the amount you're going to get when you successfully activate the pump, and the lockout interval, which is the amount of time before you can successfully activate it again. And they have to be adjusted, of course, carefully based on the patient. And so the benefits of PCA have been studied extensively, it seems that these systems may allow better pain control with fewer side effects, especially less sedation because there's less overshoot, which possibly leads to less tolerance and less dependence. There's less leftover drug that contributes to these problems. Likewise, patients have universally reported being more satisfied with the PCA, obviously because they feel more in control. I have this ability to control my own pain in my own hand, which is a tremendous psychological benefit to the patient. It does require the patient be more aware and have the cognitive ability to understand how to use the pump. And this isn't always possible in a person who does have some cognitive dysfunction, or very young children who just don't quite understand what they're feeling, what the pain really represents, and of course how to activate the pump appropriately. But if the patient is aware and does use the pump properly, the pain control is often much better and the patient is much more satisfied. Now, the opposite can occur, not with PCA, but this is a problem, again, that's been documented fairly recently. Some patients, when they receive an opioid, will actually have more pain. And this is something we suspected for quite some time, but as I said, it's actually been documented fairly well now. We're not talking about necessarily the pain is ineffective. We've all had that patient where the drug simply doesn't work, maybe because there's not enough dose. But now we're talking about the drug not being affected because of physiological reasons, or that the drug, when it's administered, actually causes an increase in pain. Opposite effect. Reasons for this? Not really clear. It seems that the drug turns on pain pathways rather than turn them off. Now, why does this occur in specific people? It's, again, not clear. Maybe due to genetic factors. There's obviously some different wiring in terms of the synaptic activity that controls these pain pathways. But the point is, if you have a patient and consistently after they get a dose of opioid, they have more pain, there may be psychological issues involved, but you can't always assume that. What we can do is monitor their pain carefully. And again, if you consistently see that pain increases 30 minutes after they get an oral dose, or after they haven't administered a small dose by PCA, you may be seeing this phenomenon right here. And it's certainly something we can document and let the physicians know. So to summarize, our major concerns about opioid drugs. We talked about the fact that these drugs are notorious for causing a fall in blood pressure when a person stands up or sits up suddenly. So as I said, we simply have to be more aware of that, be more conscious of it. We are trying to help the body overcome this, and that's the whole point of progressive ambulation. By slowly or progressively challenging the cardiovascular system to adapt to this new situation, where even if the drug is in the system, the baroreceptor response and the cardiovascular reaction to that response improve with time. And if in most cases it happens. If it doesn't happen, again, document it. You can get back to the physician and say, no matter what we do, even on a tilt table, the patient's blood pressure plummets when we get to a more upright position. Because again, maybe the drug dosage is too high, or simply another drug needs to be used because we can't make any progress, because every time the patient gets up, they have a severe orthostatic response. A second issue is respiratory depression. We did mention that this is often the cause of death in overdose. But even in therapeutic doses, we're watching for any difficult or labored breathing, that's dyspnea, or blueness around the lips and mucous membranes, or simply a fall in oxygen saturation, pulse ox. Same thing. If we're seeing this consistently, or if you think it's problematic, get back to the physician. Or a sudden increase in respiratory depression could be something wrong with the dosage, or if it's a PCA, could be malfunctioning. So be very conscious of this. And finally, we can monitor our patient's pain levels to see if the drugs are being effective, and especially to watch for that specific patient where the drugs actually have the contradictory or opposite effect of increasing pain. As I said before, we're not sure exactly why this occurs, but we may be in a really good position to pick up on it. It could be very important to the patient, maybe even, again, quality of life or life-saving if they keep increasing the dose and it keeps getting worse and worse in terms of causing more and more pain. So a very important aspect of be aware of the drugs having beneficial effects but also having possible contradictory effects. So that concludes our discussion of the opioid analgesics. And in part 2 we'll pick up on other ways to treat pain and then segue over to other ways to treat inflammation as we talk about the non-opioid analgesics and the anti-inflammatory medications.